section for risk-based contracting. Just give us one quick moment while we load up our presentation. Great. Well, again, thank you all for joining. During today's webcast, we're going to be talking about bundled payments in PinpointCare, a product that was designed to help you achieve success in this era of payment reform. During the webcast, your voices will be muted, but if you have any questions, please enter them into the Q&A panel on the bottom right of your screen, and we'll try to answer as many as we can following the end of our webcast. My name is Nate Bessa, and I'm an Associate Technical Consultant here at Galen, and I'm joined today by Rita Owens, our Vice President of Clinical Solutions, and Carla Kortner, our Lead Consultant. Now, before we begin, we're going to launch a quick poll to get an idea from the audience of how much experience you may have with bundled payments and care coordination. You'll see this poll now on the right side of your screen, and we ask that you just take a quick moment to fill it out for us. Seeing a lot of responses. Again, we really appreciate you filling out this poll. We'll give it just another 30 seconds. Great. Well, everyone, again, thank you so much for filling out this poll. Now, to kick things off, I'll hand it over to Rita.
Thanks, Nate. Sorry about that. I think I was on mute again. So welcome, everyone. We're really excited to have you join us today. And before we get started talking about bundled payments and PinpointCare, I want to stop for just a second and talk about something that you can't turn on the TV, you can't pick up a magazine, you can't look at a newspaper today where we don't keep hearing about healthcare spending, how much we're spending in healthcare. And while we don't have the numbers completely today for 2014, what we do know is that healthcare spending is skyrocketing and that it basically topped $2.9 trillion in 2013. And what we need to talk about when we talk about healthcare spending is what exactly is that? Where is that spending happening, for example, and who's doing that spending? So we know that Medicare actually accounts for 20% of the spending dollars. We know that Medicaid takes up about 15% of that. Private health insurance is 33%. And what some people don't really realize when we talk about healthcare spending is we also include in that amount what comes out of pocket. So when we talk about the $2.9 trillion that we spent in 2013, we have to also remember the fact that this is money coming out of all of our pockets as well. We're looking for that number now. It's projected that in 2020, that number is going to reach something like $4.6 trillion. That's a lot of money. Now, where is this money being spent? Well, we know it's being spent in hospital care for admissions, and those are the initial admissions, but as well those readmissions. It's being spent in physician offices, both primary and specialty, home health care, prescription drug costs has skyrocketed, medical equipment, and also over-the-counter products. All of that plays into that same healthcare spending, those dollar figures. Now, we all know that we're going to have to do something about this. So what are we going to do? We've talked about different things in the past with meaningful use and different things with the EHRs, but one thing we know is now we've all got to start taking some accountability for this. We have to start thinking how we're going to do things better and smarter and healthier. And basically, this was the theme of what's now actually being deemed an historic announcement made just a few months ago by Health and Human Services Secretary Sylvia Burwell. And I'll quote her when I'll say, Whether you're a patient, a provider, a business, a health plan, or a taxpayer, it's in our common interest to build a healthcare system that delivers better care, spends healthcare dollars more wisely, and results in healthier people. As part of that announcement, what again deemed a historic announcement, for the first time in the history of Medicare, they've actually set aside what measurable goals and a measurable timeline to meet those goals. And as part of that, one of the goals is that for Medicare fee-for-service payments by the year of 2016, 30% of all those Medicare fee-for-service payments will be tied to quality and value. By the end of 2018, that number actually jumps to 50%. So for the first time, again, we have these measurable goals and we have a timeline that we want to meet for actually bringing us away from fee-for-service, bringing us away from the type of health care that's based on quantity to the type of health care that's actually based on quality. Now, those are pretty impressive and exciting goals indeed. So how are we going to get there? Well, in particular, Ms. Burwell actually speaks specifically about accountable care organizations. She also talks about bundled payment arrangements, and that's what we want to talk about today. So our focus today for this webcast is about bundle payments. Now, for those of you who aren't familiar with bundle payments, I want to just explain a few terms so it'll make a little more sense. When we talk about bundle payments, you need to understand the terms episode of care. And what we mean by that is an episode of care basically is all those services that are provided to a patient around a specific problem or a procedure, surgery, any of those services that are provided for that patient within a specific period of time, all within this continuum of care and within like an integrated system, if you will, and all those partners. And so, for example, here, an episode of care is a pregnancy. That entire 9 months into delivery of that baby. An episode of care might be for that patient who's just had a stroke. From the moment they have the stroke and through that entire rehab, that's an episode of care. Any of those post-surgery or procedures, it could actually be the pre-surgery items that have to take place. As well, it can be that period of time associated with the diabetic, for the CAD patient, the COPD patient, for that patient who was newly diagnosed. For those patients, perhaps for that entire year, where the episode is how do we manage and that episode of care for that diabetic for this year. So keep in mind, it's about a medical problem with a specific period, and that's what we mean when we talk about an episode of care. And that's important to understand because even today in our fee-for-service world, it's still an episode of care. So for our purposes today, and to kind of keep it simple, we're going to use knee surgery as our example throughout our webcast today. So I'll start with knee surgery here. So the opposite of a bundle payment is a fee-for-service, of course. Traditionally, what we see now is for our example, knee surgery, the payers, whether it's Medicare, commercial, or for that matter, right out of your own pocket. What happens with, say, knee surgery is there is a separate invoice, a separate bill that goes to the payer. One comes from the surgeon, another one from the hospital, perhaps there's one from skilled nursing, physical therapy, and each one of these separate entities basically sends a bill to the payer, and the payer in turn sends them a check. Now, we know that this really results in fragmented care. We know in this process there's absolutely no coordination for that patient. There's nothing there. And the fact is there's basically no reward to actually coordinate that care. And what we see here is that we're actually rewarding a quantity of services rather than actually a quality of care being furnished. There's nothing in here. You don't see anything associated with that bill that basically that bill that comes from the hospital that has one thing to do with the care that patient actually received there, or for that matter from the surgeon or from the skilled nursing facility. It's just a bill. Can you imagine buying a car and basically not knowing when you drove off the lot whether or not it was going to break down 2 weeks later? So that's kind of the way our healthcare system and our spending is set up now. With bundle payment arrangements, that's different. With a bundle payment arrangement, what we're looking at is the assumption of risk associated with both the cost and the outcomes, as well as that benefiting from those savings. So with a bundle payment arrangement, and whether, and again, for our case, it's knee surgery, so whether it's the surgeon who decides to take on this risk, whether it's a skilled nursing facility, it's a hospital system, maybe it's an outpatient surgery system, whatever the entity is, once they take on that risk, then they own the risk for the dollar amount, but they also own the outcomes. And these are set up in several different ways. It could be prospective, retrospective. But again, what we would see in that same bundle when we were talking about that knee surgery, so for example, there would be a targeted price, an agreed amount, and for that one episode, so this knee surgery, if you will, and based on that price, then the person who actually owns the entity, who owns that risk, would then cut the agreed contracted price with their contracted post-acute partners there, the check for this. So again, a check would go out to the provider, one to the skilled nursing facility, the physical therapist, and the hospital again. Now, remember, we're talking about a targeted price here with these bundles. And so if you come underneath that targeted price, well, look at there, we've all got a bonus. But if you come over that, then we've got a problem. With Medicare, you actually would have to pay that back as part of their bundles. So again, what we see here is we're encouraging the care coordination that has to happen with this particular bundle. Now, as part of the Affordable Care Act, back in January of 2013, CMS actually announced the organizations that were selected to participate in a new round of bundle payment models. And as part of that, the BPCI, Bundle Payments for Care Improvement Initiative, it starts with 4 models, roughly 48 initial episodes of care. These are based on 30, 60, 90-day periods of time. And I could literally spend the entire afternoon talking about these bundles. Again, there's 4 different kinds. You basically kind of had the choice whether or not you wanted to be retrospective in payment. You get to choose the different DRGs. So again, we could spend all day talking about that. So if you're not familiar with bundle payments, I highly encourage you to, I've got the link here on my slide, to go to the Innovation Center for CMS, and everything you want to know about bundle payments is right there. So for now, that's all I'm going to say about those that have to do with Medicare. But I do want to point out when I mentioned the 48 initial episodes of care, we're talking about, while I'm talking about knee surgery today, if you'll look on those, and I've only listed a few here, it's not just ortho. We're talking about, as I do have the ortho ones here, but we're talking about cardiology, for example. Pacemaker insertions, again, cardiac valve, coronary bypass, those items where we have those post-acute care partners, those pre-acute care, all of those partners that we need to coordinate in that patient's care. We also, again, I was talking about earlier, the acute and chronic conditions. So again, whether it's a patient that's just had an acute myocardial infarction, somebody with COPD, or those long-term things that we need to manage for that patient. And basically where the Medicare or the other provider or another payer would actually pay the entities for managing perhaps one of these long-term conditions for a year with a set price of what you get paid for, what they would get paid for. And again, think about what we're doing here. Again, we want to reward the quality of care that this patient's getting. And by tying the reimbursement to the entity, to that factor in itself, we've basically done that. Now, you might ask yourself, well, is this new? Does this work? Well, actually, it's not that new. I want to talk about one that actually took place almost 20 years ago, and this was one of the first demonstrations by CMS, and it was a 5-year demonstration, and it was a heart bypass center demonstration. And in this case, it was where they wanted to be able to, we know that with heart bypass surgery, there are a lot of post-acute care partners that are involved in this. So you have the primary, you have a surgeon, you have the hospital, you have cardiac rehab, oftentimes you'll have pulmonary. So there's an awful lot that goes into the overall rehabbing and the health of this patient once they have the surgery. So again, in this particular one, it was a 90-day post-discharge episode of care, and what they found at the end of this 5 years is it saved $50.3 million for these bypass surgeries. Now, the interesting thing about this is, remember that was 20 years ago, so can you imagine what that dollar amount would be today? The other thing I want to point out here when we talk about the savings, again, when I talked about the $50.3 million, $42.3 million was a savings to Medicare. That Medicare was actually the savings that they saw and what they didn't have to pay the hospital, the providers, or those, again, the post-acute care partners in this. But also, $7.9 million was saved by the patients and their Part B insurers. So everyone actually won in that. And the other thing that was really important about this is it improved outcomes. They clearly saw improved outcomes from this. So again, while the Affordable Care Act has given us new payment models, and they're emerging almost on a monthly basis, I don't want you to think that this is something that's brand new. It works, and there's proof in it. Now, not only do we see this with Medicare, but your self-employed, your employers, as well as the commercial payers. So Walmart, Pepsi, Kroger, Boeing, to name just a few, whether they're self-employed and doing this themselves for their insured employees, or in partnership with Blue Cross, Aetna, Humana, Cigna. As well, you'll see collaboration.
Hey, Rita, I think we lost you. It looks like Rita may have just gotten disconnected. Let's just give her a minute to get back on. Appreciate your patience with our technical difficulties. Just one more minute. All right, we got confirmation that Rita's dialing back in right now. Any minute now. All right, folks, we really appreciate your patience. I think we have it now. She should be dialing in any minute.
Hi, can you guys hear me now?
We sure can.
So you just got to love that, right? All right, we're going to get started again. We're not going to let that defeat us. So let's get started back again. I'm not really sure where we left off here. Let's see. Let me make sure that there's nothing else on this phone. All right, can you hear me now? I sound like a commercial, don't I?
Loud and clear.
Okay, good. Let's get started. So I'm assuming you heard the part that I was talking about here about Walmart and the commercials, and I wanted to give you an example of one that was really exciting to me. So when we were talking about the commercials, so Walmart basically saw that their employees, when they started looking at some of the expenses that they had around healthcare spending, what they found was their employees were spending an awful lot of money on cardiac surgery, spine, and of course a few other select surgeries. And what they determined was they wanted to see a way that how they could save money on that. And so basically what they did, they set up a bundled program, if you were, that basically encouraged all their employees to have surgery in one of 6 different Center of Excellence hospitals. And part of this was that the employee would bear no out-of-pocket cost at all. So no travel, no lodging, meals, no co-pays, nothing. The entire thing would be reimbursed by a single bundle of care. Now, again, we talked about the fact that there were 6 of these Center of Excellence hospitals. And as a matter of fact, I'm proud to say 2 of those are actually Galen clients, health systems that Galen actually works with. So what they actually found as part of this was that they were able to save money, they were able to improve the outcomes, and again, you think about it, for the patient, for the employees, it made really good sense because they actually didn't have this out-of-pocket expenses, and they were able to go to probably a hospital that they might not have been able to go to. So again, and what they realized was not only a tremendous amount of savings in this area, but that the outcomes were improved for their employees. So that's an example there of one that I like to talk about that one a lot when I talk about the commercials. Also, Medicaid, so it's not just Medicare or commercial. We're talking about Medicaid getting in on this. One of the state's Medicaid programs that's really had some successful numbers is in Arkansas. So the Arkansas Healthcare Payment Improvement Initiative, where they've been dealing with bundles around CHF and upper respiratory infections and, of course, total joint replacement type of things. Also, Ohio and Tennessee have similar programs. But I want to talk about one in particular today as we talk about bundle payments and as we talk about PinpointCare. I want to brag a little bit on Illinois Bone and Joint Institute. Now, otherwise referred to as IBJI, affectionately referred to as IBJI, they actually are one of the largest orthopedic group practices in Illinois, employing over 90 physicians in every orthopedic specialty. And what they decided in the fall of 2013 is they would enter one of these Medicare BPCI arrangements. They chose Model 3, agreed on that target price from CMS, and they chose major joint replacements, DRGs, 469 and 470. And part of this is they knew this initiative was going to combine the payment for the physician, the hospital, and all those post-acute care providers into one single payment. Again, the incentive being for the providers to lower the overall cost of care through efficiency and, of course, care coordination. Now, when they started talking about this, they knew that the answer had to be simple. They had to coordinate the care. They knew that as part of that they needed, in order to be successful at this, where they would keep the cost below that targeted agreed market price, they would need to have the care coordination. They would need to have specific care plans that were based around patient-specific risk. So when I talk about patient-specific risk, I'm talking about things like a knee surgery on a patient who's 80 years old is going to come with a whole different list of risks than that 40-year-old female who maybe is needing some type of knee surgery today because she's been pounding a treadmill for 20 years. So the risk is different. And based on that risk, they knew they could have different care plans. Part of that care plan would push down to all of their post-acute care
partners. So the skilled nursing facilities, the home health, the physical therapy, all the way down. And they needed a way to track that everybody was staying on there. They knew that they would need a way to communicate with the partners. They needed a way to have patient engagement. And more importantly, in order to see where they were actually doing well and where they weren't, they needed a way to have some post-episode metric evaluation. So that was easy, right? So the answer seemed pretty simple. But actually, when you think about IBGI, who actually has over 50 post-acute care partners, providers, hospitals, skilled nursing facilities, then all of a sudden it's not so easy. When it's just one patient, maybe it's a little easier to think about bundling those and coordinating the care with all those. And you actually have the amount of patients and providers and skilled nursing facilities that IBGI had, then it becomes quite the different story. Then all of a sudden it's not so simple, and the answer is not so simple. Further, when you talk about that, you realize that every one of these entities are certainly not on the same EHR. And even if they were, EHRs just simply lack the tools necessary to plan for those specific procedures, even for that matter, certain diagnoses and conditions. Also, they needed a way to have that visibility into those partners, those skilled nursing facilities and the physical therapists, to make sure that, remember, for them, they're assuming the risk, and they needed to be able to monitor all of those partners. Again, we weren't going to be able to do that with the existing EHR. That's when they decided on PinpointCare. It was exactly what they needed. With PinpointCare, it's basically a cloud-based software, and that's what we're going to talk about today. Carla's going to give us a demo of that, and it did exactly what they needed to manage the bundle payment. It allowed them to have personalized care plan. So remember the 80-year-old patient that needed that knee surgery, she certainly has a different care plan. It enabled them to have a care plan for her, and again, the 40-year-old patient. It allowed them to be able to simplify all those pieces of care coordination that absolutely would not be able to be done with an EHR, just was not possible. It allowed them to be able to engage their patients, to have this streamlined communications among their providers. It allowed them to also be able to see when somebody was coming off plan. So, for example, if we had actually decided as part of this bundle, say for the 40-year-old, that she was going to come out of the hospital in 3 days, if for some reason she had not been discharged, they would be able to see all of this with the PinpointCare. Okay? They were able to collaborate using this particular product. And what I'm excited to share with you is some of the results that they had. Now remember, when we're talking about one patient, it's one thing, but for IBGI, what we're talking about in the period of October of 2013 to November of 2014, during that period of time, they actually involved 2,458 patients within this model. And what you see here is the results from just that 1 year, and basically once they took on the PinpointCare product. So they were able to see and realize a reduction of 6 days, the amount of days the patient actually had to stay in a skilled nursing facility. That's 6 days of payment that that Medicare would have had to pay. They also noticed an 18% drop in the overall cost for those procedures. And remember, because we're basically trying to keep that patient as healthy as we can, we're focusing on quality, we're coordinating from the surgeon, from the hospital, all the way down. They actually saw a 14% reduction in the amount of readmissions they had for those orthopedic patients and those surgeries. They saw that they were increasing patients going to home health that otherwise might not have gone to home health and might have gone home and had some issues that would have landed them right back into the hospital again with those readmissions. Ultimately, in that first year, what they realized was a savings of over $3 million. Now, that's pretty impressive. So we're excited today to bring that to you, and we're excited that Galen's actually partnering with PinpointCare. So I'll give it over to Nate and Carla.
Thanks, Rita. So now that you've shown us the shift in healthcare from a fee-for-service model to value-based care, and we've seen the incredible results as a function of using PinpointCare and bundled payments, Carla's going to take us into the PinpointCare system to show us how and why it was so instrumental in this success.
All right, I'm on. You guys, I'm excited to show this to you. I've been implementing this system to dozens of organizations this year already, so I'm excited about it. Can you see my screen, Nate?
No, not yet.
Okay.
I can see it, Carla.
Okay, good. All right. Okay, so before we get into the actual live system, I think it's important to talk a little bit about what care plans are and look at some high-level workflow as it relates to PinpointCare. Now, I apologize if this is a little bit remedial for some of you, but this is so new to so many organizations. Just because they haven't had the staff or the technology to take on care coordination, I think going over some of the basics will be helpful. So if you remember, Rita said bundle payments means one payment that covers services to all partners provided in a patient's care. They're all invested, right? They're all invested in making sure that bundle is successful. So a care plan essentially gives them that roadmap. It tells everybody what steps, what activities, what tasks need to take place to get that patient from start to finish within that bundle. So the highest level of a care plan then is the phase of care. This is kind of a no-brainer, right? In Rita's example, that knee surgery, a patient would, you would start talking with the patient about their risks, customizing that care plan. Even scheduling surgery would be a pre-op activity. They would then go to the hospital, right? They'd have their surgery. They could go to skilled nursing or maybe be sent directly to home health. But those are phases of care within a care plan. Each phase of care then could have multiple activities. Like I mentioned, in that pre-op phase, you would schedule surgery, assess risk, customize the care plan. They go to the hospital, they're admitted, there might be some progress checkpoints. You would discharge the patient, check their satisfaction. And they would go on then to skilled nursing, home health, PT, whatever is necessary as it relates to this procedure or condition. Each activity then could have multiple tasks. And this is important depending on the kind of bundle organizations have entered into. Some of them, like BPCI, will require that organizations verify medications. So you might define that within an activity as one of your tasks. So we've got phases of care, we've got activities within those phases of care, and we've got tasks within those activities. These tasks are then assigned to specific users. And this is so customizable for every organization. You know, some organizations are very large. You might have a surgical scheduler. You might have an evaluation specialist, an intake coordinator, a care coordinator. You might have numerous people responsible for managing care for a patient. In smaller organizations, you might just have one or two people, right, that do the surgical scheduling, that do the pre-op risk assessment, that would monitor the patient from start to finish. So this is customizable for every organization. You decide what phases of care apply for a procedure or condition. You decide what activities belong in those phases of care. You decide what tasks are relevant for each activity, and then who is responsible for completing each task. The other unique thing here is that partners will be able to log into the system. So this is what really differentiates it from like your EMR. Partners will be able to log in and document care on your patient within the same system, but they're only going to see patients that have been assigned to their facility. All right, so now we're going to look at how those basic concepts apply within the PinpointCare system. You know what care plans are. So a patient, once they're in the system, would be assigned a care plan. And here's our knee example. The patient's been assigned a total knee replacement. Now, patients can be entered into the system in multiple ways. They can be manually entered, but they can also be interfaced from your practice management system or from your scheduling system. So once a patient is assigned a care plan, the care plan starts to take shape, and that's what you see at the bottom of the screen here. We talked about phases of care. We talked about activities. Here you can see the pre-op phase of care, and you can see the activities, the initiating activities as part of that phase of care. So the first thing we have to do once a care plan is assigned to this patient, we need to schedule them for surgery. After that point, again, it's customizable for every organization. This organization may want to have a formal introduction of the patient to the program. If you remember or think logically about things that happen, you might also expect a risk assessment or customize a care plan But those things wouldn't be exposed to us until the surgery's actually been scheduled. So here's that step. We schedule the surgery, and the care plan starts to take a little more shape, right? Where we once had just 2 activities in that pre-op phase of care, now we've got a few more activities. We need to schedule that pre-op evaluation, complete the risk assessment, personalize the care plan. You can see which activities are required by the red asterisk in front of the activity. You'll also notice where we once just had the pre-op phase of care in our care plan, we've now got the acute phase of care starting to take shape at the bottom of the screen here. Once we selected a surgery date, that became our admission date at Glenbrook Hospital in this case. So care plan's really starting to take shape here. The next thing we might do in the system would be to evaluate risk. You know, like Rita mentioned, to coordinate care, we've got to really evaluate each patient on an individual basis. We've got that 80-year-old patient who had higher risk, maybe has diabetes or congestive heart failure. That's going to be a higher risk patient than that 40-year-old woman who's been pounding the treadmill. We can assess that using an evaluation with dynamic scoring. Again, this is customizable for every organization. You decide what questions are asked in that risk assessment for this procedure. You decide how these risk assessments are scored. But as you complete a question for a patient, and in this example you can see we might fill in weight, height. We might ask them things like, do you have stairs to get into your home? Do you have somebody that's able to take care of you after surgery? Do you have transportation for your appointments after surgery, for your post-care? As you complete answers to those questions, the evaluation score is going to be adjusted. As that score goes down, the risk goes up. So that 80-year-old patient who has all those comorbidities is going to probably be a lower score and a higher risk. You would then use this information to customize your care plan. Because a patient who is 80 and higher risk may need to spend a little longer in the hospital. They most certainly would need to go to skilled nursing, where that 40-year-old patient may be in and out of the hospital. They may not need to go to skilled nursing. They can skip right to home health. So the customization of the care plan within Pinpoint allows you to do all those things. You can select a location and decide with that patient where they're going to go for each phase of their care. You can update a length of stay. So as I adjust this length of stay, and this is defaulted by your organization, by the way, but as I adjust the length of stay, my due dates on the activities will adjust as well. So here I've got a length of stay of 3 days, and the due date is May 31st. If I adjust that length of stay to 4 days, the patient would then be, you could plan that the patient would be discharged on June 1st. The other thing you could do here, as I mentioned, would be to delete a phase entirely. So that 40-year-old patient who's going straight to home health, we delete that phase, and then it's not necessary to follow that in the care plan. So lots of flexibility here, very customizable by each organization and for every patient, which is important when you're trying to manage that bundle. Once the care plan is customized, we go back to that detail screen. Here's our care plan, and now it's really starting to take shape. Where once we just had the pre-op phase of care and the acute phase of care, now we've got skilled nursing, home health, PT. If I were able to scroll down the screen, we're going to look at this in the live system as well. But this really isn't what EMRs do, right? They collect clinical data. They collect all the labs and histories that are necessary to take care of a patient, but they don't really make it easy for a care team to know where a patient is in the continuum of care. This is also a little more robust than something like a call center software might provide, because all parties involved are able to log in, document, and stay engaged. Everybody can see what the due dates here are for each activity within each phase of care. Everybody can see what has been completed and what is not. So a green check mark would indicate to me that that activity has been completed. An orange box would indicate to me that that has been started but not finished. And these gray boxes would indicate to me that those activities have not been started at all. We're going to see a lot of other detail on the screen when we get into the system that would indicate to us whether or not patients are on plan or off plan, and where we need to be concerned. So like I mentioned, and like Rita mentioned too, one of the keys here is to communicate with your partners. Everybody is invested in making sure the payment, you stay within that bundle, right, to maximize your financial gain and not take any risk from this patient within this bundle. So to do that, you do have to be able to communicate with your partners. You need to know that a patient is on track once they leave the hospital in this example. Once they go to skilled nursing, what happens to them? Today, it's very hard to know that in your EMR. PinpointCare really goes a long way into fixing that situation. An acute care partner, in this example here, could log into the system, document the discharge details, and that is then updated in the system. You can see in the lower part of the screen here, the status changes to complete, but also any deviation from the plan is documented. So where we thought the patient was going to be discharged May 31st, they actually didn't get to leave until June 2nd. So a little red flag to the care coordinator or the care team. They can get engaged and see what they can do to get that patient back on track. Another example, skilled nursing would log in. They would document the admission. And again, the care coordination team, they can see very clearly where the patient is falling off plan. Again, this is really important, right, in bundle payment programs, because there is financial incentive to keeping a patient on track. I think it's also important, of course, to make sure that the care is optimized and quality is there. But this is going to help all partners involved see where a patient is and where things are falling off track. Organizations can then start to trend which of their partners are performing well and who are consistently falling off plan. I don't know if you guys read Modern Healthcare, but I read earlier this week an article about Banner Health, how they had investigated operations and quality of care at something like 100 SNFs in their area. They ultimately chose to only work with 34 of those SNFs. So you can imagine how much easier that process would be with the kind of data that's available here in PinpointCare. So a care team managing hundreds or thousands of patients can't really look at every patient's care plan every day, right, to see who's on and off plan. So the next thing I'm going to show you in the PinpointCare system is the dashboard. A care coordinator or care team could easily log in and see which patients are off plan. They could also drill a little further into which activity the patient has fallen off plan for. I'm not going to spend a whole lot of time on this screen because I'm going to take you into the live system and actually show that to you. And then we've got role-based work lists. Everybody has to know what they're responsible for. As I mentioned earlier, each task is assigned to a user, and you as an organization decide which users are responsible for those tasks. But everybody's going to have to know what they have to do. The skilled nursing staff have to know what's outstanding for them, the home health people, the scheduling coordinator, your intake specialist. They live off of this work list, and it will tell them what's due for them in the next 5 days, or they could change the date range for that matter and look at what's due for them tomorrow or within the next 2 weeks. They can further filter the results in a dozen different ways. But we'll get in the system and take a peek at that. Actually, let's just go ahead and do that now. I know everybody's anxious to just get in there and see what it looks like. They get logged in. One of the other cool features about this system, it's architected in such a way that it allows for very easy changes to be implemented. So as customers start using their care plans, everybody thinks they want it one way, and then, after you start using the system, you want it another way. It's very easy to implement those changes without downtime. Okay, so here's the dashboard. I've logged in as a care coordinator, and I've given this user actually numerous roles, so you're going to see a lot more information here than a typical user might see. But on the dashboard here, I've got patients that are off plan, and I could then further filter the patients I see here by the care plan. So if I just wanted to see patients that are in a knee care plan, I could filter for those. If I wanted to see just those patients who were off plan in a specific phase, I could select that piece of the pie. What's maybe more useful, though, is to look at activities. If I want to see patients that are off plan in skilled nursing, I could look and see which activities are falling behind schedule. So I can see Allison here. She was supposed to be discharged May 7th, that's 6 days ago, as her care team or care coordinator. I'm going to have to do something about that. I'm going to click on Allison and go into her care plan. And here you can see very clearly it shows me that this patient is off plan, and it shows me at which step she's off plan. So here's the skilled nursing phase of care. Here's all the activities within that phase of care. She was admitted on schedule, but she ended up staying in skilled nursing a little longer than anticipated, or is still there. Maybe she hasn't been discharged. And it could be that that skilled nursing partner just hasn't completed the documentation, or it could be that the patient is still there. So as a care coordinator, I would want to follow up and find out, what's going on with that patient. We're going to look now at the work list, as I mentioned. Lots of robust functionality here. Like I said, I've set this user up with lots of different roles, so this is a little more chaotic than a typical user would see, but very simple for me to filter by phase if I just want to see those activities in home health, if I just want to see those pre-op evaluations that I still need to complete. I can also look for a specific date range. I can filter by specific doctor or location. I could also just start typing a name here to filter my list only to those patients or surgeons or locations. Lots of robust functionality. I could then, as a user, launch into this activity. I know I need to complete this risk assessment or this pre-op evaluation for patient Rita Rhodes. I can very easily go into that activity and complete my task. I wanted to take you into this one because this is that dynamic scoring risk assessment, and I think it's pretty cool. So here, I talked about this a little bit earlier. Does the patient have to negotiate stairs? If I say yes, you're going to watch this evaluation score drop. And I can set up dependent questions. So does the patient have 1 to 5 stairs, 6 or more stairs? Are there handrails? Are there stairs to negotiate at home? What's the bathroom set up like? So you can do lots of things with this risk assessment. It's very robust, very customizable for every organization. But you can see the value in evaluating risk like this so that you could customize a care plan for a patient. Speaking of customizing care plans, I do want to show you that here in the live system really quickly. So this is our patient, Rita Rhodes. She's having knee surgery. I know she's going in for surgery on May 29th. It's here on my screen. And I can adjust that length of stay. I could also set a location. If I know where she's going to be cared for home health, I could select a location at this time. And like I mentioned earlier, I could also delete a phase. If outpatient physical therapy weren't necessary, I could delete that phase entirely. And that could be added back in later. But you can see how easily these phases of care can be adjusted. Once that's done, it would update all those activities on the patient's care plan and change all the activity due dates to reflect the length of stay we just saved here in the personalization of the care plan. Lots and lots of other functionality I'd love to show you in the system. We just don't have time for today, but I'm sure we'll do more webcasts in the future, and you're always welcome to reach out and we can do a more personalized demonstration for you. All right, Nate, tell us how Galen can help our customers implement the system.
Absolutely. Thanks a lot, Carla. So Galen is the exclusive software reseller for PinpointCare, and there are a variety of services that we can offer to help you adopt this product. These include interface configuration with ADT demographics and SIU appointments through your EHR, as well as project management and payment model implementation, workflow design and training, and integration with patient engagement tools, such as Galen's own Dragonfly mobile app. So we have some time today for questions. As well, I'd like to say that if you do have any questions, you can also still enter those in on the panel to the bottom right of your screen. First up, the first question we would like to ask is the PinpointCare solution only good for orthopedic organizations?
Well, I'll take that one, Nate. No, it's not just for ortho. There are a lot of applications for a system like this. Really, any organization that's interested in care coordination, right? The care plans are customizable. While we looked at ortho and while we looked at phases of care that basically ran sequentially, they can also run in parallel. So no matter what kind of care coordination you're doing, or if you're in a bundled payment program or not even, this can be set up for your scenario. The oncology care model, for example, people just started signing up for that through Medicare. You could have maybe a surgical phase of care, then a chemo phase of care, radiation phase of care, nutrition, rehab, psych. Those could run in parallel. So lots of applications here outside of ortho.
Thanks, Carla. Another question we got was, we are an ACO. Can we also participate in bundled payments?
I'll take that one. So this is Rita. So absolutely. Actually, being in an ACO actually situates you in such a way that you've already began to coordinate with the different entities in your area. So you're perfectly positioned to be in part of a bundle payment.
Great. Another question. How long does it take to implement PinpointCare, and what does that process entail?
Gosh, that's so, it depends on every organization. I'd say in general, it takes about 8 to 12 weeks or so to implement a system like this. It really just depends on the size of an organization and what prep they've done before starting this implementation process. Have they all agreed on a care plan? You guys know how complicated it can be to get 100 different providers to agree on one care plan. So has that been done? You would compile your list of partners and physicians, users, determine what users are responsible for what tasks, go through the system configuration. We'll customize those care plans for you. Probably some interface build. We are able to interface registration data, scheduling data. Obviously, several rounds of testing would probably be included, training, and then your big launch. It's a pretty simple implementation, and they really go pretty rapidly.
Cool. So we got another question now from Brad. Does the care team only contain your organization, or will you be able to include contacts for follow-up?
Does the care team only contain organization? I'm not sure I understand the question, but the care team that has access to the system could include people outside of your organization. So your skilled nursing users would be able to log in and complete information. Your home health partners, an example for oncology care, maybe it's a nutritionist or psych, they would be able to log in and document care for that patient as well. So not just within your organization, but outside your organization as well. Again, that's really, one of those things that your EMR probably can't offer. Your skilled nursing partner, your home health partner, they're probably not on the same EMR that you are on. So it makes this kind of coordination of care very difficult, and that's one of the things that makes PinpointCare so successful. I see the follow-up question from Brad, actually. And yes, so his question, he was asking if a user of Pinpoint would be able to know who to follow up with when there are gaps in care. The answer is yes. They would easily be able to tell what partner they needed to follow up with for each phase of care and furthermore for each activity.
Okay, thanks a lot, Carla and Rita, for answering all these questions. It looks like these are all the questions that we've received. So if you do come up with any questions later on, or if you had more questions that you would like to ask, you can reach out to us at sales@galenhealthcare.com. We'd also be happy to do a more in-depth demo and talk to you more about PinpointCare to kind of discuss with you why it might be right for your organization. You can also access all of today's slides through our wiki, and you can also go to our website at galenhealthcare.com to view all of the additional services, products, and many other great things that we do. Again, thank you all so much for joining. We hope you learned a lot, and please let us know if you want to talk more. Thank you. Have a great afternoon.